cow's milk, casein, beta-lactoglobulin, alpha-albumin are most frequently evaluated components. And basophil activation test, which is a functional test, unfortunately is not available clinically, but in research setting can be very helpful to assess the status of food allergy. Once we have established suspicion of food allergy, for Ig-mediated allergy, we usually implement a dietary elimination trial, which can be followed of 2 weeks, which can be then followed by a oral food challenge, which is typically supervised in the clinic or in the hospital under the direct observation. So history is paramount, as I mentioned before, because this really allows you to determine if the manifestation, if this adverse food reaction has really immune mechanism and type of immune mechanism. So the history entails asking about what food was ingested, amount, as well as the form of the food. Was it raw or baked or somehow processed? It's important to inquire about the cofactors: exercise, alcohol, non-steroidal anti-inflammatory drugs, anti-acid, whether the food was taken on empty stomach or after a large meal, concurrent febrile illness, of course, flare of comorbid conditions such as asthma or allergic rhinitis. Also for females, menstrual period, sleep deprivation, as well as stress can be relevant, particularly in older patients. We want to ask about time to onset of symptoms following food ingestion, and then, of course, specific symptoms, which organ system they arrive from, and the treatments administered and the response to treatments. For the non-Ig-mediated food allergy, we really don't have diagnostic tests. They are there's no evidence of systemic IgE for a vast majority of the patients. So history is even more important than physical examination. And just to point out that for the non-Ig-mediated food allergy, diagnostic elimination diet trial usually is longer, between 2 to 4 weeks. Oral food challenge should follow diagnostic elimination diet trial in non-Ig-mediated food allergy. It should be done under supervision of the physician, but it can be done in the clinic or hospital setting for conditions like food protein-induced enterocolitis syndrome, or could be done at home for proctocolitis or enteropathy. Food allergy diagnosis is very important because food allergy has a very significant impact on the quality of life of the affected patient and the entire family. So if we misdiagnose allergic rhinitis, of course, it's a negative experience for the patient, but it doesn't have as far-reaching consequences. As you can see, all aspects of life, social life, nutrition, and at every moment are affected by this diagnosis. So some of the largest burden of food allergy, one is fear of serious allergic reaction and fatality, but also this impression of lack of freedom. So there's not a minute in the life of a food allergic patient that they can really relax. So the underdiagnosis obviously has the associated risk of an allergic reaction, but overdiagnosis also is associated with unnecessary burden, the psychosocial consequences, increased financial costs. Those patients are responsible for co-pays or cost of the epinephrine auto-injectors, special diets, as well as special care, childcare, school and camp arrangement, and of course, nutritional consequences. So the landscape of food allergy diagnosis has changed. So before 2008, we would really rely on measurement of specific IgE to whole foods. And this also was associated with the sort of black and white approach to food allergy management with total avoidance of the offending food. from 2010 until now, we have the capacity to measure specific Ig to individual allergens which are typically proteins referred to as components. And this is available through immunoassays such as ImmunoCAP or ISAC microarray. And this has been also associated with introduction of more nuanced management of food allergy with, let's say, introduction of baked egg and baked milk diets. And in the future, really we hope to be able to diagnose food allergy utilizing detection of specific IgE directed against the individual allergenic epitopes on the components, and this will lead to the individualized management. So the management in the past was that strict food allergy avoidance, so black and white. Currently, we are introducing more shades of gray, allowing patients tolerant to baked milk and egg to introduce those foods in the diet. Patients with pollen food allergy syndrome are allowed to ingest cooked or processed plant foods. And then there are also patients with birch allergy who have very mild symptoms to peanut or tree nuts were also allowed to ingest those foods in the diet. And in the future, hopefully this approach, this management will be even more personalized based on the individual profiles of the allergenic activity. So currently, proactive approach to modified allergen avoidance is based on the molecular characteristics of food proteins. So there's big distinction between animal proteins versus plant proteins. The underlying concept here is susceptibility, heating, and processing for animal proteins. And this clearly refers to cow's milk, hen's egg white, but also to meat, fish, and shellfish, where different forms, raw versus boiled versus smoked, may be tolerated differentially. Regarding plant proteins, this differential diagnosis is based on cross-reactivity with pollen and susceptibility to digestion. And this is represented by peanut, tree nuts, also wheat, fruits, vegetables, and legumes. Specifically for cow's milk and hen's egg, the ability to tolerate baked milk and baked egg are associated with different susceptibility to high temperature among different components of those foods. So generally, cow's milk casein and hen's egg ovomucoid are more heat stable than whey or ovalbumin proteins. So you can appreciate here the gel as gel of the boiled cow's milk that was boiled up to 90 minutes. And you can appreciate that the band for casein doesn't change significantly throughout 90 minutes, but beta-lactoglobulin, alpha-lactalbumin, which are the whey proteins, the bands become significantly weaker and fainter after about 15 minutes of boiling, suggesting that high temperature does affect the integrity of the protein. This may not be as easily appreciated in case of the ovomucoid or ovalbumin. Apologies, there's some immunoblots missing from that slide, but what I can tell you is that for the ovomucoid, the band that was representing heated ovomucoid was significantly fainter. It was similar to the unheated ovomucoid, so there's no change in binding. This is immunoblot, so we're now investigating binding of IgE to those proteins versus heated ovalbumin that shows significantly weaker binding of IgE from patients with egg allergy. And again, suggesting that ovalbumin has higher susceptibility to extensive heating. So our studies with Dr. Hugh Sampson have discovered that actually majority of milk and egg allergic children can tolerate baked milk and egg in the form of a muffin, and some of them also tolerate baked cheese, such as pizza, which are staple foods for American diet. Depending on a study, between 60 and 80% of those patients tolerate baked food. And that children who are tolerant to baked milk and egg typically develop tolerance to unbaked milk and egg faster than those children who react to baked milk and baked egg. They are able to ingest baked products before they're able to ingest non-baked products. And in particularly for cow's milk allergy, reactivity to baked milk is associated with a different phenotype. So baked milk tolerant children have milder allergy than baked milk reactive children. And they also become tolerant much later at a slower speed than children who tolerate baked milk. And there's some controversy from the literature. It's not entirely clear whether adding baked milk and egg to diet accelerates tolerance development to unheated milk and egg. This may be in part due to the different ages of the patient when the baked proteins are introduced into the diet, as well as the sort of, in general, the concept of the free eating with the introduction of baked milk and baked into the diet of those children. This is just sharing the results of the ROC curves derived from the large clinical trials of baked milk diet. And I hope you can appreciate that for the three lines represent different components. So the cow's milk Ig is represented as blue line, the casein Ig is represented as a black line, and then beta-lactoglobulin Ig is represented by the red line. We have shown that casein had the largest area under the curve, although it wasn't as dramatic as you'll probably see in a presentation of Tim. But we propose some decision points based on those studies with a large number of children, 225. So positive decision point above which we would not consider in the clinical setting. A food challenge to baked milk would be casein of 20 kilounits per liter. Optimal decision point would be casein Ig of 5 kilounits per liter, and negative decision point would be casein of about 1 kilunit per liter. So for casein of 5, we would estimate about 50 chances of passing versus failing, which seems in many clinical settings as the sort of acceptable risk to benefit ratio. Similarly, for the diagnosis of egg allergy, it seems multiple studies have shown that ovomucoid IgE is superior for diagnosis of baked egg allergy. So this is a Japanese study from Ando and colleagues, which showed that for the raw egg allergy, which is confirmed by a supervised food challenge, a specific egg white IgE has the highest area under the curve, and this is shown as a green line, versus for the allergy to heated egg, the specific Ig to ovomucoid, which is shown as the blue line, has the highest area under the curve, so best diagnostic performance. So that study proposed positive decision point for ovomucoid about 10 kilunits per liter and negative decision point of 1 kilunit per liter. So patients with ovomucoid levels greater than 10 kilunits per liter would be considered not great candidates for a clinic, for a challenge to the baked egg in the clinic, versus those that have ovomucoid level less than 1 would be considered a much more favorable candidates for the challenge. Similar studies where results have been derived from the cohort of Finnish children. So this is not specific to a region or sort of characteristics of the population, where the ovomucoid specific Ig levels differ the most among the patients regarding reactivity to the baked egg. Again, another study from Japan, more recent, showed that confirm the findings, prior findings, now broken down by the age. And I just want to point out that lower, in general, lower specific IgE have higher positive predictive value for younger ages, and then you can see that at any for any age group, measurement of a mucus-specific IgE was superior to the measurement of the whole egg white specific IgE. So I want to now introduce a case. This is a 3-month-old infant with eczema. So new onset of generalized erythematous itchy rash, not sleeping well. She's been seen by a pediatric dermatologist, diagnosed with atopic dermatitis, but despite a proper management with topical corticosteroids, weight wraps, and bleach bath, she continues to have active eczema. Although her atopic dermatitis rash improved after her mother stopped breastfeeding and started hypoallergenic formula, extensively hydrolyzed casein formula. It should be mentioned that the mother is anaphylactic to peanut as well as tree nuts. So now we are going to go to the polling questions. And I would like you to read the question, to take time to reflect. And the question is, what foods would you test by skin prick test to identify triggers for eczema rash? There's a single choice for the answer. You could choose foods based on the history of eczema flares with maternal ingestion of specific foods. You could decide to test egg white, cow's milk, wheat, and soy as the most common triggers for food allergy in infants with eczema, or you might choose to test for peanut and tree nuts because of the history of allergy to those foods in the mother. So I'm going to wait for the responses to the poll. So I think we're still going, but you were right. You know, you could choose the foods based on, so most of you chose the answer 1, choose the foods based on the history of eczema flares with maternal ingestion of specific foods. But I want to point out that this is incredibly unreliable. So for instance, in our patient populations, the typical foods that are being identified are, you know, tomatoes and oranges and some of those acidic foods. So this correlation is very imperfect. So really the recommended approach to testing an infant with poorly controlled atopic dermatitis is to test them for the most common food allergens in that age group. So in that case would be egg white, cow's milk, wheat, and soy. Okay, so let's move on. So I'll show you the results of our testing. So actually we have performed skin testing as well as serologic testing for that patient. And we have found that skin prick testing was actually negative to most of the foods, and except for almond, which was tested as a, you know, as a tree nut representative because of the maternal allergy. And the IgE testing showed much more significant positive levels, which you can appreciate here, but fortunately her RAH2 was negative for peanut, and peanut was negative, although interestingly almond, cashew, as well as hazelnut IgE were positive. So our recommendations were to perform a physician-supervised oral food challenges to peanut, wheat, baked milk, and baked egg. So we started from a peanut food challenge, and it was a successful challenge. The infant ingested 2 grams of peanut protein. We also performed a wheat challenge, and she's tolerated wheat challenge. But then we had a situation where she had an accidental ingestion of milk. There was the mother put 1% milk into her bottle. alcohol. She drank about 1 ounce, and that had violent emesis times 4. She was recommended to go to the emergency room. She wasn't prescribed an epinephrine autoinjector, and the father mentioned that she was having some difficulty breathing in the emergency room. She has developed systemic hives all over. There's no additional emesis, and she was treated with epinephrine with improvement. So here's the next question for you to consider. What would you advise regarding milk avoidance for this infant? Would you defer food challenge to baked milk since she had a recent anaphylaxis to non-heated milk? Would you obtain additional specific IgE to casein, or would you proceed with baked milk oral food challenge without additional testing? All right, so here we are more split with most of you choosing to obtain additional specific IgE to casein, and also deferring food challenge to baked milk. She had a recent anaphylaxis to non-heated milk, or the minority would proceed with the baked milk food challenge without additional testing. So it is I think each of those answers are actually quite reasonable, although we could discuss pros and cons for each option. And we have actually, because of the difficulties obtaining testing, which is only available to us as serologic testing, we did not obtain specific IgE, but we had a recent house milk IgE was quite low. So at that point, we've decided to proceed with the challenge to bake milk in the clinic. So this child ingested a total of 1/4 of a muffin, which was the design for older children. And this was a serving size, which was appropriate for her age. And she has had no allergic symptoms, and she has tolerated baked milk muffin. And so she was discharged home well. So I think this case is illustrative, and I'm sorry for being confusing for many of you, but just to point out that the results of the allergy testing are a general guide, and you can always make a decision based on the importance of the food, nutritional or social importance, and to perform a challenge if it's potentially beneficial for the patient. And in this case, the child was also in the daycare, and there were older children having foods with baked milk, so it was important to determine if she would tolerate the milk in the baked product. So I want to move on to wheat allergy very quickly. Wheat is the most important source of vegetable protein in human diet. It's also one of the most common childhood food allergens, as well as in adults. Wheat has been recently highlighted as an important trigger of anaphylaxis. Patients with wheat allergy severe wheat allergy will react to trace amounts of wheat. The estimated prevalence is about 1% in Europe in children, and even in adults in the US. The more recent studies also place the estimate about 1%. But of course, the self-reported prevalence of wheat allergy is higher than confirmed prevalence. The problems with current wheat allergy diagnosis is that it's quite confusing. The diagnostic decision points with high positive and negative predictive value could not have been established for wheat. This is probably related to polysensitization and concurrent sensitization to grass pollen. Up to 65% of grass allergic patients have detectable wheat IgE without any clinical manifestations. And furthermore, some allergens unstable or water insoluble may be underrepresented in whole wheat extract-based tests. classification, to date, about 27 wheat allergens have been listed on allergen.org, and you can see that they can be divided on water salt solubility into water soluble albumins and globulins, represented by alpha amylase inhibitors and lipid transfer proteins, and water insoluble proteins, which is gluten. And gluten has two fractions: gliadin, that is soluble in alcohol and water mixture, and glutenins that are dilute in acid. And gliadins are associated, sensitization to gliadin is associated with the risk of more systemic and more severe reactions. So here's just an overview of the manifestations of wheat allergy, and this can manifest as classic wheat allergy, such as, that is more common in infants and children, wheat-dependent exercise-induced anaphylaxis, Baker's allergy, and particularly relevant for Japan, hydrolyzed wheat protein allergy that is present in cosmetics, where sensitization occurs through the cutaneous application. I just want to point out how wheat component can be helpful. They can identify primary wheat sensitization and exclude cross-reactivity with grasses or other grains, assess risk for severe reactions, and overall improve patient management. So in the US, we have currently available whole extract and gliadin, Tri-A14, which is lipid transfer protein, and Tri-N19, which is omega-5 gliadin IgE tests for clinical care. And I would just want to focus on wheat-dependent exercise-induced anaphylaxis, which can occur in children, which is induced by physical exercise, and wheat is tolerated at rest, and it can manifest as generalized urticaria or severe anaphylaxis. So many studies have highlighted the importance of omega-5 gliadin IgE measurement in patients with wheat-dependent exercise-induced anaphylaxis. This is a British study of large number of adults, and the positive IgE was present in 100% of those patients, where wheat IgE was positive in 59% of those patients, and gluten IgE in 76%. So suggesting that omega-5 gliadin is most helpful in for diagnosis of wheat-dependent exercise-induced anaphylaxis. Another Japanese study also highlighted that for patients with wheat-dependent exercise-induced anaphylaxis, omega-5 gliadin was detected the most at highest frequency, and it has not been detected in patients with wheat allergy and atopic dermatitis. An Italian study also suggested that omega-5 gliadin is the most important allergen to identifying patients with anaphylaxis. Patients were sensitized to omega-5 gliadin. 85% of those patients had history of severe systemic reactions, versus patients were sensitized to a lipid transfer protein, Tri-A14. 44% of those patients had no reported reactions to ingestions of wheat. And the patients who were positive, sensitized to Tri-A14 were also co-sensitized to other grains, barley, oats, rice, corn, versus patients were omega-5 sensitized, were allergic, co-sensitized to shrimp as the most common co-sensitivity. Here, I just want to point out that in those patients with severe anaphylaxis to wheat, most of them had really low wheat-specific IgE levels, but really high, as you can see in this column, frequently less than 1 kilonewton per liter, versus really high levels of omega-5, so Tri-A19 IgE, and almost undetectable for majority of the patient negative GRAS IgE, suggesting primary sensitization to wheat. And just the most recent study from Germany, which showed that wheat anaphylaxis is particularly severe. The study focused on the adults, and most patients of those patients were sensitized to Tri-A19, versus only one patient was sensitized to lipid transfer protein. in summary, the authors concluded that most adult wheat anaphylaxis were associated with omega-5 gliadin sensitization. Those reactions occur frequently in patients without atopic background and present with severe cardiovascular symptoms, and that wheat-dependent exercise-induced anaphylaxis is common for anaphylaxis in patients. So patients with recurrent urticaria, adults with recurrent urticaria or idiopathic anaphylaxis should be evaluated to exclude wheat allergy. So remember, omega-5 gliadin is associated with wheat-dependent exercise-induced anaphylaxis, and it is poorly represented in wheat extract, as can be seen by comparison of wheat-specific IgE results. So there's also Baker's allergy, which can be caused by inhalation or topical contact with wheat flour or dust. It's an interesting occupational allergy, but there's no specific wheat component that can be suggested for Baker's allergy. So here's a diagnostic algorithm that can be, recommended for evaluation of patients, and detecting positive wheat IgE or gliadin IgE should be associated with further, could be associated with further component measurement, patients with detectable omega-5 gliadin IgE are greater than 0.1 kilograms per liter should be viewed as patients with high probability of primary sensitization and severe events. Remember, interpretation of the allergy test should always occur in the clinical context. So for instance, patients that have positive gliadin, detectable gliadin IgE, and the patients, if the symptoms are present, then you should consider that patient had high risk for systemic reaction. Patients who have undetectable gliadin, but detectable wheat and or A14, so lipid transfer protein, and then those patients should undergo further evaluation depending on the clinical context. So the final polling question is that of a 14-year-old male who presented with 3 episodes of whole body rash, cough, wheezing after playing basketball during school recess after lunch. It was treated with oral antihistamines. He has unrestricted diet and plays basketball regularly, but he's overall an allergic person. He has intermittent asthma, allergic rhinitis symptoms, and as a child, early in infancy, he had atopic dermatitis. He has eaten pizza on one occasion, cheeseburger on second, and grilled cheese on the third. So here's the final polling question. What is the best diagnostic test to identify the food trigger for food-dependent exercise-induced anaphylaxis in this child? Skin prick test to milk and wheat, specific IgE to milk and wheat, specific IgE to casein, or specific IgE to omega-5 gliadin? All right, wonderful. So this was much more straightforward. Omega-5 gliadin, indeed, this patient has had detectable omega-5 gliadin. So the components do improve diagnosis of wheat allergy. They rule out clinically relevant sensitization due to cross-reactivity. And then remember, omega-5 gliadin, as well as gliadin, are associated with more severe reactions, are helpful to identify wheat-dependent exercise-induced anaphylaxis. This can result in improved patient management. So key messages for my presentation is that molecular allergen analysis or component-resolved diagnostics is key to personalized management of food allergy, and food allergen avoidance may be modified based on the individual patient profile, resulting in improved quality of life and nutrition. So we are moving from the black and white and gray to the life in full color. Thank you very much for your attention.
Thank you, Prof. Anna. That was truly a very comprehensive and excellent talk, and lots of questions rolling in, but we will save the question and answer for the end of the session, and we'll move on to our next speaker, who is going to present on the diagnostic approach to peanuts and tree nut allergy. I'm very excited to welcome Dr. Tim Brettig, who is a pediatric allergist and immunologist working at the Murdoch Children's Research Institute in Melbourne, Australia. He is currently undertaking a PhD exploring the diagnosis, investigation, and clinical management of tree nut allergy in children. To date, Dr. Tim Brettig's PhD involves a systematic review of the accuracy of available diagnostic tools for tree nut allergy and a health economic assessment of alternative diagnostic pathways to skin prick test in the diagnosis of cashew allergy. He also works as an honorary fellow at the Royal Children's Hospital in Melbourne and in private rooms at MACCS Medical Group, where both outpatient assessment and oral food challenges occur. Thanks, Tim.
Thank you. Thank you for the opportunity to chat today. So today I'm talking about the diagnostic approach for peanut and tree nut allergy. So I'll start with a bit of background, but peanut and tree nut allergy. So peanut, as you're all probably very well aware, is a ground nut, which is classified as a legume, and botanically it's unrelated to tree nuts. However, tree nuts are quite a broad group, which for the purposes of allergy, we consider as dried fruits that are found within a shell and used in food. And so for the purposes of this talk today, I'm speaking specifically about cashew, pistachio, hazelnut, almond, walnut, pecan, Brazil nut, and macadamia. So we know with peanut and tree nuts that they're the main culprits of near fatal or near fatal reactions. And we also know that they're the cause, or people with peanut and tree nut allergies have more recurrent reactions that are usually more severe, with a higher number receiving adrenaline than what we'd see typically when we combine all foods themselves. The natural history has been touched. So peanut and tree nuts have a fairly poor prognostic outlook compared to other foods such as milk or egg, with peanut thought to be around 20% resolution through childhood, and tree nuts slightly lower at around 10 to 15%, although the data on this is limited due to the individually the lower prevalence. Prognostic markers, or good prognostic, positive prognostic markers for resolution include less contaminant food allergies, history of resolved food allergies for other foods, and interestingly, atopy or the severity of reaction, so whether they had anaphylaxis or not, is not a good prognostic factor for resolution. When we look at them collectively, peanut and tree nut, they share similar prevalence. This is based on Australian data, but looking at around 3.3% in 6-year-old children for peanut and 2.8% for tree nuts. And this continues up until the 10 to 14-year-old children, so 2.3 for peanut and 2.7 for tree nuts. We know that for tree nuts specifically, the prevalence for these vary geographically. So in Australia, we see that cashew is the most common of the tree nut allergies, whereas in the US, it's slightly different, with walnut and cashew being more dominant. And Europe has quite a lot of variation within Europe, but we tend to see a more even spread between walnut, cashew, but also hazelnut as well. Is very important. When I talk today, we're talking about sensitization versus true allergy. And when I say sensitization, I mean a positive test result. So when we look at the prevalence of peanut sensitization in 1-year-old children, an Australian study looked at sensitization of 8.3%, whereas the actual rate in a similar group of confirmed peanut allergy is much lower at 3%. And it's a similar story for tree nuts as well. So the prevalence of tree nut sensitization is quoted at, it's quite broad, but quoted at somewhere between 1 and 12%. However, the prevalence of confirmed tree nut allergy is much lower, again at somewhere between 0.3 and 5%. One of the most complex, or the biggest clinical dilemmas we have, is that if we do screening, so performing multiple tests to foods that have never been ingested, we can find that for tree nuts in particular, many patients are sensitized to 5 to 6 on average when they're young, whilst only around 50% are allergic to just 1 to 2. So getting a high rate of false positive results. We do know that there's co-reactivity, so high cross-reactivity between tree nuts has been shown, and that's thought to be due to the presence of similar epitopes, and so found more commonly in genetically closely related nuts. And I've just tried to outline that fairly briefly as to which nuts are closer to others botanically. We know that around 20 to 30% of children with a peanut allergy are also allergic to 1 or more tree nuts. And that's a common dilemma we have, and I'll touch base on that later in my talk. But for an individual with one tree nut allergy, at least one other is seen in almost half. But as I mentioned earlier, 55% of these are only to one other itself. And then when we specifically with co-reactivity, we know that it's not a bidirectional relationship. And so when we're looking at those with a pistachio or pecan allergy, almost all of them are allergic to, so pistachios to cashew and pecan to walnut. But if you look the other way, it's not quite, so 65 to 83%, so 64% of cashew allergics are also allergic to pistachio, whereas 83 of walnut allergics are allergic to pecan in 2 studies that have looked at that. So as we've touched on, I think this is probably a slide that will be very common throughout all of our talks, but a clinical approach to food allergies. So we've got clinical history, which is really important. So the history of an allergic reaction to a food or a possible allergic, and also a risk of allergy depending on comorbidities. That gives us, I guess, our initial and a clinical assessment, so including examination, gives our initial understanding of, do we think that allergy is likely? And we can investigate that. And the main ones that we use commonly at the moment are skin prick tests, as well as blood tests, so specific IgEs to the whole nut or component-resolved diagnostics. And the outcomes from those in combination is we're either left with an outcome of allergy, so avoidance, an inconclusive result. So we would need to proceed to a food challenge to get a definitive diagnosis, or a negative result, which could therefore suggest reintroduction, which could either be supervised in a food challenge, or if it's thought to be very low risk, it could be done in a home environment, and that differs in different areas, I appreciate. With the avoidance, I've got that dilemma of, are we avoiding because of true allergy, or are we avoiding because of sensitization? So that's where it comes down, I guess, looking at the diagnostic test accuracy in itself. And peanut's the best studied out of all of the foods I'm talking about tonight. However, peanut allergy is highly unlikely when we have a skin prick test of less than 3. So it's got a very good negative predictive value. However, if it's greater than 3 millimeters or equal, then there's a fairly low specificity. The area under the curve, so for peanut skin prick test is defined at 0.89, which is quite good. And we've also got 95% positive predictive values for children of different ages. So originally, it's fairly well accepted that 8 millimeters, but it's been shown in multiple cohorts now. So 1-year-old infants, it's 8 millimeters, but at 4 years in the same population, it still remains at 8 millimeters and is reinforced through other studies. Serum IgE to whole peanut appears a bit more variable. So previously established thresholds we saw around 15. That's generally what's been accepted as an acceptable cutoff value. However, we've also seen in similar populations that described our skin prick test outcomes above that for 1-year-olds that may be much higher, whereas the 4-year-old group in this population, so again a different population, was lower with 2.1, and the AUC is poorer as well. So skin prick test generally outperforms the SIG to whole peanut. Interestingly, looking at again a population cohort at age 1, peanut skin prick tests of greater than 13 millimeters or equal, or an SIGE of greater or equal to 5, gave a 95% positive predictive value for persisting peanut allergy at 4 years of age. So I guess that helps somewhat with giving families an understanding of prognoses as well. And along with other factors potentially as to how often they need to be reviewed. And then more recently, we've also seen that peanut components. So RH2 is one of the peanut components, of which there's been a number described, but this at this stage appears most accurate, but also other studies have identified RH6, RH8, and many others. There's also been papers that have looked at combinations of components to increase the accuracy itself. But overall, in isolation, the AUC of RH2 is defined at 0.92. So again, very similar to skin prick test, slightly better. But there's fairly limited evidence in using RH2 as a standalone test. And again, I'll talk about this a little bit later in my discussion today. So tree nuts, often referred to as a group, but the diagnostic tests for tree nut allergy are quite distinctively different in terms of their accuracy. So what was previously assumed as a general cutoff for all is being increasingly shown to be quite different. And there's also quite a lot of gaps in our knowledge when we evaluate tree nut allergies. And the main issue for that is that there's a lot of studies that will report a retrospective clinical food challenge outcome. So that's a clinician making an assessment to proceed to a food challenge. And so we've got a selection bias that's probably, it's less reliable as far as a cohort compared to looking at, say, a population group where they'll all have a skin prick test and all have a food challenge regardless itself. So this has formed part of my PhD, but generally when reviewing diagnostic tests, there's a number of points which I'll go through in detail rather than reading these out so far. So generally when we're looking at assessing tree nut allergies, the skin prick test outperforms a whole nut IgE in terms of accuracy. We've got examples of cashew as a skin prick test. We've got 95% PPVs reported at 10 millimeters in a community population and between 12 to 14 in an allergy outpatient specific population. Got a good area under the curve and fairly reasonable sensitivity and specificity. Contrasting with that to the SIGE to cashew, you've got quite broad optimal cutoff values that have been described through numerous studies, and also a lower area under the curve as well. Sensitivity and specificity again is still reasonable, but not as good as the skin prick test itself. And for walnut, a similar study, similar outcomes have been shown. So optimal sensitivity and specificity generally is accepted around 5 to 6 millimeters, but the area under the curve is a little lower than cashew, but with good sensitivity and specificity. Whereas the SIGE to walnut, there's a very large range in the optimal cutoffs of between 0.4 and 2.5, with a slightly lower area under the curve. So of all the tree nuts, cashew appears the most accurate. The ANA03, which is the cashew nut component, is the most predictive for allergy compared to its skin prick test and whole nut IgE. So cashew has a 95% PPV for both skin prick test and ANA03 in different studies itself, and for that. So the second point is that 95% PPVs as well as cashew have also been reported for walnut, but outside of that, there's not a lot of 95% PPVs that are described in good populations. Hazelnut has had a lot of research, however, was not able to find, they found quite a broad optimal cutoff, and that probably relates to Europe, and as well as pollen co-sensitization impacting that. So cashew, as I said before, we've got 95% PPVs. For ANA03, the 95 PPV that's been reported is a greater or equal to 2. And also there's some limited data, but there still is data looking at basophil activation tests. So that's growing in the tree nut area with evidence towards basophil activation testing. Walnut has 3 studies looking at 95% positive predictive value with using a skin prick test of 8 millimeters. With components, there is one study again showing that JAAFCA, so JAAFCA and JAAFCA seem to be the most useful components in walnut, but JAAFCA is the one with a 95% PPV at this stage. And again, some limited data looking at basophil activation testing. So I think the other thing which probably happens because we've got lower prevalence individually, but there's quite a broad range for the populations where we don't get 95% PPVs. There's a very broad range in optimal cutoffs. And that's just what I'm trying to say here is that, say, with hazelnut SIGE, we've got a range that's very large, as well as core A14, which is the hazelnut component, has a very wide range of optimal cutoff values depending on the population that was described in their relevant study. And we've got the other end of the spectrum, and I think probably one of the more important things for me is there's very limited evidence for the remaining nuts, and almonds are a great example where we see quite a high false positive rate, both with skin prick test and almonds, whole almond SIGE. So whilst these are the studies that look at clinician referred food challenges, you can see with these 2 studies, particularly at the bottom, there's still a very high food challenge pass rate with a very positive skin prick test. So 90% of skin prick tests greater than 8 millimeters were passing in this study, and a similar result with the other published study as well. Outside of these nuts, there's really no significant or good studies that would report values for, say, Brazil nut or macadamia that would impact significantly clinical outcome. But looking at the testing in isolation, it's also that we can improve, or feel that you can also improve these by combining some of these tests as well. So using algorithms to improve our accuracy. And this has been shown quite well in peanut allergy. And primarily we use that at the Children's Hospital down in Melbourne. We've been using that for over 5 years. But it's been previously described using a peanut skin prick test as your first investigational test. It's the point of care test. And then if within the range of 3 to 8 millimetres, they then proceed to have an ARA-H2, and that would be our decision as to proceed into food challenge. So obviously for these patients, they've got a clinical history that's amenable to having a food challenge, so an inconclusive history or a long history of no accidental exposures and reactions. But this study that was published in 2012 showed a 58% reduction in food challenges required. And I think this is a key sort of part moving forward with a number of these different tests, is that at least in Melbourne or in Australia, we find that we do have limitations with food challenge service availability. And so if we're testing to a number of foods, sometimes we're not able to actually offer a food challenge because of limitations on seats or hospital spaces. And so therefore we are left with accepting a diagnosis or delaying the introduction of that food. With tree nuts, there's not been a lot of work yet at looking at diagnostic algorithms, but we're starting to explore those for difference. And so one of the chapters for my PhD is looking at cashew. So looking at cashew serum IgE followed by ANA-O3. And with that, modelling using some pooled data from different studies around the world, I was able to show that we could get a significant reduction in number of food challenges compared to using skin prick test alone. Interestingly, and possibly because our ANA-O3 AEC is a lot better than some of the other components, ANA-O3 on its own actually performed very well. And we had a reduction of almost 80% for both using either ANA-O3 or a two-step algorithm, which used first to cut off the cashew IgE followed by ANA-O3, comparing that to skin prick test for cashew. So we significantly reduced the food challenges, and then doing some modelling, the cost to the health system was reduced by almost half from that alone. So I think this would be something I would like to start to incorporate into clinical practice, hopefully moving forward, because we're still getting quite reasonable correct diagnoses, as well as a very low rate of false negative diagnosis. And I think a false negative diagnosis in our setting would mean that we're having less home reactions, which is of primary importance. And then lastly, looking at prevention of tree nut allergy or screening. I think this is one of the common questions or dilemmas that we have. And so screening really comes from, I guess, looking at what's the risk of allergy to this person before they've ingested the food. And we had information from, I guess, the LEAP study early on. They're looking at early introduction of peanut, reduce the development of peanut allergy, but also it's been shown with others such as egg as well. There's been a change in practice towards early introduction that's been recently demonstrated through the early nuts cohort, which is again a Melbourne-based population study. And they saw that there's a 16% decrease in peanut allergy prevalence over the 10 years. There's been a real shift from delayed introduction to early. However, there's not any significant data yet on tree nuts. Interestingly, only 5% of the Australian cohort from 10 years ago were introducing cashew before 12 months of age. So it's generally delayed introduction at that stage. So we screen essentially because we're intending to avoid a severe reaction when introducing the food. However, the question always remains, what is the risk of severe anaphylaxis or fatality, which is obviously a primary concern. But most of our presentations with initial food reactions are mild or moderate reactions. And I think that's always a dilemma. There's different guidelines between the different governing bodies. ASCIA, which is the Australian Allergy Immunology Society, their recommendation has been to avoid testing in all groups, but encouraging introduction and early. And that's NAIAD had recommended strongly considering screening in infants with severe eczema, egg allergy, or both, and avoiding testing in low to medium risk groups, but encouraging early introduction. And IARCI, the European Society, has recommended avoiding testing to peanut in all groups, including those considered higher risk itself. So using that in Australia, we found that I think there's a real push away from screening for peanut allergic infants for tree nut allergy, which is exactly what we would have done 10 years ago, and encouraging cautious home introduction, using handouts and guidelines, and having a contact as needed if there were to be any issues with any of the introductions. The exception primarily would be someone who's had a severe reaction that was considered a very high risk, so peanut anaphylaxis would generally probably get screened by most clinicians. For a patient who presents with a tree nut allergy, I would say that most clinicians, at least in Australia and Melbourne, would screen to other tree nuts, given the increased risk of a further tree nut allergy I've outlined earlier. However, one of the things that is always a laboured point is that if we've got limitations in the accuracy for a number of tests, particularly with different tree nuts, where is the benefit in testing to those foods? So there is a shift now where we're really trying to move towards testing to the foods that have got only the best diagnostic accuracy or evidence. So say cashew, pistachio, walnut, pecan, and probably hazelnut, but avoiding testing to the other ones such as Brazil or almond until we have definite outcomes for the initial ones. And I guess that's the crux of the testing dilemma, is that we need to, I feel that it's really important that we can, if we do a screening test or a test with a low initial likelihood of allergy, we need to have a food service that can challenge to those foods. If we were to have, if you were testing, say, tree nuts and you tested all 8 tree nuts, if you get, they're all sort of 3 to 5 millimeters, which is our worst case scenario, that may mean 8 food challenges. And it's really hard then to try and work through that and introduce these foods to a patient. We talk about the risk of reaction. We talk about the low prevalence of some of the other tree nuts in itself, and we work through from a most common to least common approach. And if they then react, then we could stop and reassess. But I think the key is always when we're making those decisions about which tree nuts should we be looking at, is how is that result going to change the decision I make? Am I going to go to a food challenge regardless, or would I actually ordinarily be considering this to be low risk, and therefore they could trial that at home in itself? So my key message is that I think clinical history and understanding the co-reactivity and prevalence for nut allergies, particularly in your local regions, are most important in the assessment of a child with suspected food allergy. And we've got diagnostic tests such as skin prick tests, IgEs, or component IgEs. These form part of the diagnosis, but there's still quite significant areas where we've got very limited evidence for tree nut allergy diagnosis in particular. And then adequate access to and the approaches for reducing the need for food challenges. We should be considering these to reduce the burden on a food challenge service so that we can get definitive diagnosis as required. And algorithms are one approach that we may be able to use to improve this accuracy. Thank you.
Thank you, Tim, for the excellent talk. And I think we'll proceed without any further ado to Dr. Agnes' talk, and she's going to present on novel diagnostics for seafood allergy. Dr. Agnes Leong is the Assistant Professor of the Department of Pediatrics in the Chinese University of Hong Kong and a Fellow of the Pediatric Immunology, Allergy and Infectious Diseases subspecialty. The main goal of her research is to analyze the patterns, causes, and effects of immunological disorders, in particular food allergy, in the Asia-Pacific region, in hope to provide effective preventive methods and safe treatment options. She has received major grants to conduct translational studies to determine the usefulness of component-resolved diagnostics for seafood allergy, and her team's discovery of biomarkers for fish and shrimp allergy diagnosis has led to 2 US non-provisional patents. Thank you, Agnes. Thank you, Agnes.
Thank you, Lydia, for the kind introduction. Hope you can see my screen. So it's a real pleasure to be in the same platform with you guys, my friends, teachers around the world. So I would like to talk to you as the last sessions of today, the novel diagnostics for seafood allergy. So the main learning objective is to really look at the pitfalls of the current conventional diagnostic test. What are the emerging roles of CRD in seafood allergy diagnosis, as well as other exciting novel diagnostic tools? So this is a figure from the JAAFCA molecular allergology recommendation. So it's quite dated. So as with other food allergies, history is of paramount importance. We need to know the type of allergic reactions that your patients have, whether it is an immediate type of reactions. For that, we would be inclined to order specific IgE testing, such as Ite quantification tests in vitro or in vivo skin prick testing. If it is a delayed predominant reactions, then we would consider something else, such as a double-blind placebo-controlled food challenge, or we analyze whether it could be related to other toxin poisoning. But after a test result with the specific IgE test, we would stop here with either recommendation of food allergen avoidance or determination whether the patient needs an oral food challenge. And often we are stuck at this gray area here because of the pitfalls in the current seafood diagnostic tests. So it needs to be updated. And today I'm going to talk about the potential options that we have. So this is an elegant study done in Italy showing the allergen profiles in the different commercially available skin prick tests. You can see these lane 1 represents the protein profile of fresh stream extract, and the rest represented other commercial stream extract used for skin prick testing. You can see the vast differences in the protein content in the different skin prick tests that are available commercially. Most importantly, the major allergen that was believed to be causing the allergic reaction in stream would be the 35 kilodalton line here representing tropomyosin, and is absent in a number of the extract. The authors also try to look at the allergen, the IgE reactivity profiles of the different stream allergic patients, and found interestingly, very different patterns of IgE reactivities. Some were allergic predominantly to the tropomyosin, but some patients, some groups of patients reacted to the high molecular weight proteins, which were less commonly talked about. So you may immediately thought about, so if there are a huge heterogeneity in the skin prick test extracts that are available, what about directly using the fresh streams, the prick-to-prick tests? But I would say that there is also heterogeneous results from the different studies that I've looked into. So one of them is from the Thời, which directly look into the performance of skin prick tests to stream extract, the commercially available stream extract, versus prick-to-prick test to cock stream. And they challenge these patients with an open stream challenge, the open labeled one. So in the end, they found that only the crude stream extract were significantly different between the positive and the negative challenge groups. But no difference was observed in the prick-to-prick test result to cock stream. This is a disappointing one, although the same group also found that the prick-to-prick extract could actually be quite durable. It can stay in 4-degree, like a refrigerated temperature, for up to a month. So the stability is good, but the performance, it highly depends on the method that you use, the extract that you use. So we still need more data on that, and whether we can use prick-to-prick test for the diagnosis of stream allergy. Another more objective test that we can consider, of course, is IgE quantification tests. So this studies is done in Singapore, looking into 100 patients with reported stream allergies. And in the end, using oral food challenge to glass prawn and tiger prawn, they found a third of them were shellfish allergic, stream allergic. A third of them were actually stream tolerant. They could eat the stream without any adverse reactions. And then a third of them were actually sensitized to dust mite and stream tolerant. So they found that using skin prick tests or IgE quantification with immunocap tests, they yielded a good sensitivity, but the specificity is very low. You can see essentially the groups who are stream allergic and the group who are stream tolerant, a lot of them has a positive sensitization to stream, and as well as skin prick tests with other like stream species. So it's very poor in really distinguishing the groups who are allergic and tolerant to shellfish in the Southeast Asian setting, and this is probably related to the house dust mite cross-reactivity. The performance is similar with IgE quantification with immunocap, and what I have not shown is that authors also try to include specific IgE to stream tropomyosin with the ISAC test, but of course it did not improve the diagnostic performance substantially. Very differently, this is another study done in the States, I think it's from Texas, looking into stream allergic patients. And in this group of patients, they found that using stream tropomyosin, so this is stream extract, this is stream tropomyosin, and this is dust mite component. They found that in those who are actually non-dust mite sensitized, stream tropomyosin is a good test. So if you're living in the States, colleagues of Prof. Anna, and probably you can still consider the use of tropomyosin in your region when you're evaluating patients with suspected stream allergies, but probably not so useful in the Southeast Asian setting or regions with a predominant population with dust mite sensitization. So here we goes back to the long well-known mite crustaceans molars syndrome. It is because of the presence of tropomyosin, which is the pan-allergen, not only in crustaceans, but also in molars, in dust mites, as well as in cockroaches. Studies in China have found that those who are sensitized to cockroach, a lot of them has cross-reactivity to shellfish to crustaceans. And it is possible that sensitization of tropomyosin is by inhalation from non-crustacean sources. So typically, shellfish allergy presents later on in life after one has developed allergic rhinitis. So this is, it looks complicated, but essentially it's looking at the sequence homology of tropomyosin in different species. So this is tropomyosin in shrimp, in lobster. It has a very high sequence homology to dust mites. So you can see more than 80% of sequence homology. But as with the sequence homology to mollusks, scallop, mussels, abalone, only around 50% of sequence homology. So you may be able to actually tolerate mollusks when you just look at the sequence homology profiles. So this is a big problem in Southeast Asian setting. Luckily, tropomyosin is not the only thing that we focus on now. So we have a lot more components that have been reported. So it goes, it's very relevant to today's topic, the use of CRD in a clinical setting. So apart from tropomyosin, we have identified other molecules which may be of clinical relevance, including arginine kinase, myosin light chain, sarcoplasmic binding protein, troponin C, as well as this triose phosphate isomerase. And our group have also recently identified a number of components of the tiger prawn. So there are hemocyanin, which is actually found to be a cross-reactive proteins in the stream allergy, as well as other important components, including fatty acid binding proteins, glycogen phosphorylase, as well as enolase and aldolase. And we have registered these components in the WHO nomenclature. So if interested, you can take a look. So this is a study done in collaboration with our Thai collaborator, Professor Panchama Pachan's group. So we look into patients who are confirmed to be stream allergic by oral food challenge, those who are tolerant with passing of a double-blind placebo-controlled food challenge to stream. Those with probable stream allergies are those with a convincing history of stream allergy, as well with sensitization more than 0.7. And we compare them against the Thai group, who also have a convincing history of stream allergic reactions together with a positive sensitization. So here is the interesting part. We found that other than tropomyosin, there are a lot of different important components in our stream allergic patients. So instead of tropomyosin being the major components in these stream challenge positive patients, troponin C, glycogen phosphorylase, sarcoplasmic binding proteins, they are found to be important allergens in our group. And it is in contrast with the group in Thai, who are found to have fatty acid binding protein as well as troponin C together with tropomyosin being the major component. So it is really important to know your patients, to know what components that they are actually allergic to. So this is looking at the ROC curve of using the different diagnostic tests. There are a lot of lines here, but essentially you can see when we look at the performance of skin prick tests, specific IgE to stream extract, the performance is only fair. So which is the purple and the green line here. But if we use component-based tests, we yielded a significantly higher area under the curve compared to extract-based tests. And more importantly, our study found that tropomyosin may not be the important allergen across different populations. In the Thai group, it may add diagnostic value, but not in the cohort in Hong Kong who have been challenged with a double-blind placebo-controlled food challenge. Instead, troponin C, sarcoplasmic binding protein, and fatty acid binding proteins may be the components that we need to watch out for. We need to have more work, validation work, to see if these components can improve the diagnostic accuracy. So it is important to really know your patient. So here comes the poll questions to understand your patients. So I'll wait for the poll questions to come. Right here, you should see the question here. So which of the following is the major stream species consumed in your region? So it is important to know what stream species that your patient are allergic to, so that you know what to test them with. So it is there are studies done in the Thai region, Southeast Asian region, looking into patients who are specifically allergic to Macrobrachium rosenbergi, which is a freshwater prawn. So they found that the selective prawn allergic patients, the major allergen is actually hemocyanin, which in our population is a cross-reactive protein, but in their cohort is an important allergen. Oh, so I love this answer. So most of you have actually got no idea. So it's you should, in part of your history taking, also try to see if you can elicit what stream species they're allergic to, because it may be important. So I'm going to show you why. So I've talked about the importance of selective allergies to giant freshwater prawn, and we have actually got a cohort of patients who are specifically tolerant to freshwater prawn and only allergic to the saltwater prawn. So it's not like peanut. If you're allergic to like peanut altogether, but it's more sophisticated with seafood allergy. And for that, I also wanted to highlight the different stream species that are used in the different commercially available tests. For immunocap test that you are using, PAN-A1 is the only component commercially available and is extracted from the brown stream, which is popular in the States, but not so popular in Southeast Asia. As with immunocap, the extract that we are based on is from the Penaeus monodon, the black tiger prawn, as well as from the northern stream. However, for Letopenaeus vietnamese, which is also popular in Southeast Asia, they're actually not included in the commercially available specific IgE extract. Rather, you may find it in one of the skin prick test extracts, or the more popular commonly used extract is actually based on crayon, which is actually a European stream species. So that's a fun fact to know. And here comes the last part of my talk. The novel diagnostic tests are available. So I would say this is a very sophisticated test, which I found it to be very helpful in the clinical setting, but of course it needs the laboratory expertise. So there are the basophil activation test as well as the ICSAL test, which is a very fancy test that we like to use these days. For basophil activation test, instead of looking into IgE quantification, we look at how IgE cross-link after allergen stimulation, inducing the basophil activation. And we do that by measuring the upregulation of the surface protein. The most common one would be the CD63 markers. The limitation is that it's quite costly and it has a short sampling window. Using a similar concept, but I would say is logistically better, would be the ICSAL test. So it requires a culture of a cell line, a cell that has been transfected with a luciferase reporter gene. Using the same principles as BET with IgE cross-linking, it will induce luciferase expression, and the full change in the luciferase signal will represent the degree of basophil activation. What the beauty of it is that you can actually use your archive serum samples, and it does not have the short sampling window as with the basophil test. You do not need to run into the laboratory and stand by all the time, and it has a relatively lower cost. So our group has found that compared with the conventional tests, including skin prick tests and the specific IgE to extract-based tests, you can see that the use of BETs like IgE functional tests and XL, it yielded a much better area under the curve, a higher diagnostic value. So this is represented by the purple line, and the orange line here, BETs using different concentration of stream extract and component. Compare to the use of, you see the skin prick test, the red line here, the blue line is the IgE quantification with extract base. So overall, the functional test has a better diagnostic performance, and using a single step test, you can see we are much better at differentiating patients who are eventually challenge positive to stream. So with the use of BETs, we can identify more than 90% of patients who are truly stream allergic compared with the use of conventional tests, including skin prick tests and stream-specific IgE testing. So here comes to the last question, and near the end of the talk, is to whether you will truly understand the beauty of basophil activation tests. So which one of the following is not the limitation of basophil activation tests? Whether it's a low representation of allergen components, higher cost than skin prick tests and specific IgE tests, short sampling window, long process time up to 6 hours, and the lack of standardization of laboratory procedures and data analysis. So which one of the following do you think is not the major limitation? So we still, I think, need some way before we have a standardization of the laboratory procedures for BET, but it's a promising test, and I would describe it as oral food challenge in a test tube. So it's one of the best tests that we have currently. So we see a bit of a mixed response. So I think my question is not structured in the best way with a double negative, but overall, I wanted to bring out that BET is not limited by the allergen component. You can test it with both components as well with extract base. So our group has tested it with both the Penaeus monodon, tropomyosin, as well as with the extract, and we still found it to be superior to the commercially available tests. But it has this limitation. So this is a summary table here and concludes my talk here. So the limitation of BET is still the short sampling window, the long process time, and still currently lack of standardization across the laboratories. But it has the best and highest AUC, the area under the curve, compared to the commercially available tests. As with the skin prick test and specific IgE tests, they are sensitive, but at the moment they cannot overcome the cross-reactivity with dust mite, which is the major problem in the Asia-Pacific region. So you can go back to the slide if you're interested by looking at the recording. So in summary, seafood allergy is very important, particularly in Asia. But currently, the commercially available assays cannot have its limitations. So components seem to be promising, but we need to know which are the major components that are clinically relevant in our own population. So you need to know your patients. And I've shown you that functional IgE tests, BETs, and XL improve the diagnostic accuracy. And ultimately, what we want is to avoid unnecessary oral food challenge and dietary restrictions. And collaboration among the Asia-Pacific centers and even with Western countries with Professor and his group are much needed to really improve the overall diagnostic performance of shellfish allergy. So I'd like to thank everyone who have contributed to studies, and I welcome anyone who are also interested in this area. Please contact me if you have any questions that I cannot answer today, or if you are interested in knowing more about shellfish allergy. So thank you very much.
Thank you very much, Professor Anna, Dr. Tim, and Dr. Agnes. These are 3 excellent sessions. They generated many questions, and I see that many of the questions have actually been answered in great detail by both Dr. Tim as well as Professor Anna. So I'll move on to the remaining open question, which is for Dr. Agnes. Is there any sensitization difference between urticaria and anaphylaxis patients in shrimp allergen components?
Thank you, Lydia. That's an excellent question. So at the moment, we did not find any significant IgE sensitization pattern that points toward a severe phenotype. So I think it may be because we do not have enough patients who truly have anaphylaxis to stream to get that answer. So I think we need to work together. But at the moment, I do not have the answer to that, but I think in the past we're just focused primarily on tropomyosin, and this is probably the reason we cannot find a specific IgE sensitization pattern of the severe phenotype group. But with the component-resolved diagnostics that are emerging, so it's something that we should work together on.
Thank you, Agnes. Yes. I think we have, I just wanted to ask Tim one question, if I can. I really enjoyed your presentation. I wanted to ask you what the cutoffs are that you are using for your cashew and NLO3 projects. Yes.
Yeah, thanks. So the cutoffs that we used for the skin prick test, we used the 95% positive predictive value. So we used 12 millimeters because we were looking at an allergy clinic cohort. So obviously there's a fair range of people that will fall into the mid-range with that, because you can't, it's difficult retrospectively to take the clinical history component, which is fairly is very important. The cutoffs for the cashew IgE was the lower cutoff for all of the IgE, so to cashew or to ANA03 were less than or equal to 0.1. KUAs per litre, and the cashew SIGE was 8.5, and then we use 0.35 for ANA03. And that's, I think, we use those cutoffs because there was a smaller study that just looked at a group of about 35 patients and looked at a similar algorithm, and they identified that was got their best accuracy. I think looking at the pooled data that we got with 4 different studies, the true cutoff's probably a little bit higher than that. In reality, we've got a 95% PPV of 2 as an example. But because they're pooled data, I couldn't combine them. They were too different. There's different ages, different populations, different cashew allergy prevalence and things as well. So I think whilst the concept of the algorithm, I think is quite good, I think it could still be better by using that in a prospective trial. As an example, with the Children's Hospital in Melbourne, that we have done RH2, but we actually haven't looked at how has that impacted our food challenge services yet, despite using it for 5 years. If we did something for cashew, it'd be a great opportunity to look at that in the real world prospectively, to see actually how much is it impacting, and therefore what's our best cutoff, because we'd eventually get higher numbers.
I just, if I may, Lydia, just to emphasize that the cutoffs are helpful, like as a concept, but I mean, they are really not like the gold standard. They will change, based on the age, based on the concomitant, like comorbid conditions. So, with atopic dermatitis, they will. We don't have cutoffs for adults. So I think you have to be aware that this is just like a general guide, and then always your clinical judgment for clinic. I'm talking about clinic, your judgment, the patient history, the importance of the food. I cannot emphasize this enough. If the food is important, then you're, risks, you are willing to take higher risks, right? Compared to benefits. And like, I can just share that for my clinic, like we usually We actually look at the size of the wheal relative to histamine. And in general, like a very general guide, if the size of the wheal to the food is equal to the size of the wheal of the histamine, my discussion with the parents like 50-50, like equal chances of tolerating versus reacting. And everybody has a different tolerance of risk. Some parents want to have zero risk. Some patients are willing to try the food if the risk is higher, like 95%. Because they feel it's important to really know. So it's a complex process, but just remember, you always have your you as a physician, as a clinician, you're the highest kind of decision maker, and the parent or the patient, right? Like you can always challenge the patient if you think that this is going to benefit the patient.
Thanks, Anna. That's really a helpful and a very relevant point, actually, as the data is relevant for groups of people, but it has to be applicable to the person in front of you. Yeah.
Lydia, may I ask a question?
Yes, please.
I had a question to Anna, and especially about baked milk, and because we come across children who actually do not react to heated milk, but they react very severely to even a very, very small, like 0.5 ml of unheated milk. If you do an oral food challenge, even as they are 7 or 8 years old, So which component would you say would be most relevant in this, and like what's the guiding standards? Like, would you just continue them with the baked milk in their diet?
Yeah, so are you so that's a bit unusual, because we found that, like in all of our studies, and it may be again difference between the populations, if the child passed the baked milk challenge, but it's a significant amount, right? Like our muffin is 1.2 grams of milk protein, so it's an ounce of milk, really, right? So they don't have serious reactions to milk. Even if they react to unheated milk, they have milder reactions. So if you have a large population of patients, it might be worth publishing, because this is different from our experience. But casein is the most important. We've known for a long time that if somebody has high levels of casein IgE, they will take longer to acquire tolerance. And casein is less heat labile, so it's more resistant to heating. So if you really have high casein IgE, then your chances are lower of tolerating baked milk. But I also say that if you have really high total IgE, you're also much less likely to tolerate heated milk, because to have a high IgE, you have to recognize multiple epitopes on the protein. So, if you have a milk IgE of 50 or over 100, it means that you are binding like crazy to everything, to, whey proteins and to casein. And it's unlikely that baking is going to destroy all of those epitopes, even on whey proteins. So, just for lower cow's milk IgE, I think casein is going to be very informative. If you have really high, whole milk IgE, then be careful. Just even if casein is lower, but you have like whopping levels of whey proteins, those patients will be less likely to tolerate baked products, because you will never destroy all of those epitopes that are relevant for them on whey proteins. But generally casein.
Can I ask another question? So this is to Anna. It was really interesting to see that the study by Endo, which actually used heated egg itself. So not really in a muffin form, but heated egg for 60 minutes. And there are some protocols that actually use baked milk, not in a muffin, but just baked itself. Yeah, and I think to many parents, they would feel that this is easier to perhaps, or they would like to know if the child can tolerate a larger amount of milk. But in my experience, or in my reading, most of our studies of baked milk have been for the muffin. So do you know of advice or just a general approach to this sort of baking milk itself? Yeah, it's probably an intermediate step.
No, actually, it's a great question, and there are commercial products in development for exactly that, for that purpose, because our the premise for the baked studies were like, oh, it should be a food that is relevant for, and it sounded like, okay, muffins should be okay, but then they get tired of it and they don't want to eat it, and people don't want to bake. So I think it has to be for the population like US, it has to be something you can buy. You don't rely on people doing it at home. So, but it's very tricky because it will burn. Like it burns. So it's really the process is, I think, would be very difficult to accomplish at home. It has to be like a commercial, processing with deglycosylating milk and to be able to heat it at high temperature or bake it without the matrix. Yeah, but great thinking.
Yeah, I think in this region, I mean, I won't speak, at least here there are still people like to make things at home. It's much I think they feel more confident and comfortable. I had a question to Agnes. Lydia, may I?
Yes, please.
So Agnes, you were talking, the two things I had actually. One was the role of exile, because I'm very much interested in that. And could that be a very good source of, because not every department has large number of people, because for food challenge, you need people to actually run those challenges. If you want to do large number of patients, it's difficult. So they have a long waiting period. So if, compared to that, would exile be a good substitute for not just seafood allergy, but for other food allergies? That's my one question. And the second question, you mentioned hemocyanin, because I know people who are like, if you completely deshell the shrimp and even remove the black wing, they do not have any allergy to the rest of the shrimp. So it could be the hemocyanin in it. So what's your experience on that?
Thank you, Prof. Ruby. They're great questions. So I think Excel is a very promising tool because it works in the same principles as BET. And in our fish and shellfish allergy studies, they have been found to have the highest area under the curve, the best diagnostic performance. It doesn't require 6 hours of long labor-intensive work and immediate processing of the blood samples, but it has only been validated in egg allergies and now in shellfish allergy in my group. So we need more work on it, but potentially it may be the way to go with an Excel test, similar again with BET, a test tube, or for challenge in a test tube. And as for hemocyanin, you are right that it's mainly found in the blood. So when we want to look at the recombinant protein, we will draw the blood from fresh stream. So if you heard that your patient's history is that, oh, they're only allergic to fresh stream, but not the older stream, or if they're only allergic to the shell of the stream, hemocyanin may be the component that you are looking for. And this is often cross-reacting between the shellfish species as well. So yeah, so it is interesting to know that. So
thank you. Thank you.
We still have 2 questions. So perhaps we can quickly, if the patient develops severe anaphylaxis due to LTPs in the wheat, would the best solution be avoidance, or is there any difference in management from true wheat allergy?
Well, I guess that's for me. No, if they have anaphylaxis, I mean, the lipid transfer protein is sort of a transitional protein that can be associated with oral allergy, but also with systemic reactions. So even in the history, there is anaphylaxis, although rare, and you have sensitization to lipid transfer protein, then your clinical judgment comes in. And if you have doubts that that this person actually reacted to wheat, then I would say challenge them, under supervision carefully. But if they, if wheat was definitely what caused the anaphylaxis, and then you find sensitization to LDP, yes, this patient is truly allergic and they should be avoiding wheat.
Okay, thank you, Prof. Anna. And I think we are somewhat over time. So this has been such a informative and productive session. Thank you for all the wonderful questions, and to our three panelists for the very illuminating talks. So thank you so much. And I'll hand the time back to Prof. Ruby.
Thank you, Lydia. I am really grateful to Prof. Anna, especially. She's actually speaking in wee hours of her morning. Deeply grateful for being here and giving us such a wonderful talk and answering all the questions. It means a lot to all of us in the Apache community, not just the younger generation, but to all of us. I also thank Agnes, who's been leading many of the initiatives, and she's for her excellent talk. And also to Tim, who's also at the other side, late night there, for being on this forum and giving such an excellent talk. And for Lydia to moderate the whole session so beautifully. So I really appreciate everybody in this forum, which I think was an outstanding session. I also deeply appreciate all the attendees and all those who are part of the Apache community, the Apache family. We will always gather together to have these excellent sessions, and we look forward to you continuing to join us in our future initiatives. But please feel free to write any questions that you were not unable to send. You can write it to us and we'll get them answered to you. And before I'd like to end my closing remarks, and after my warm thank you to everybody, the panelists, the speakers, the moderator, and the attendees, and the staff behind the scenes who have been running the show, I'd like to invite all of you to the Apache Allergy Week, which will be celebrated between 16th and the 22nd of May. We have this every year. We had it last year on COVID-19, understanding the facts and the myths about the vaccines. We tried to address the vaccine hesitancy. We had collaborated with the World Health Organization and with parliamentarians for that. This time, our topic is also a very much important topic. It is in line with the World Health Day. It's climate change and air pollution and its impact on our allergic diseases. Of course, it goes beyond allergic diseases, but we focus on allergic diseases. So on May 17th, from 1900 hours to 2100 hours, there will be a live webinar. This timing is a time for Singapore, Hong Kong, and Malaysia. So from 1900 to 2100 hours, we will have a live webinar, and this is the program. We will circulate this to you. We're very honored that in this forum, which is on climate change, global challenge, impact on allergic diseases beyond the pandemic, we will have very key speakers. We have the regional director from the United Nations Environmental Program, UNEP, who will give us the opening address. This will be followed by the chair of the Air Quality Asia. It'll be followed by a keynote lecture by a parliamentarian, Legada from Philippines, followed by also Dr. Jairam Ramesh from India, and also Dr. Katie Allen from Australia, both parliamentarians. And finally, a lecture by Prof. Stephen Holgate, who has been a champion of the Clean Air Act for the UK government and also worked in this space a lot for several years. And we will have a panel discussion like we had last time with regional experts who have worked in this field. So I invite you all to join us for this Apache Allergy Week 2022 on May 17th. And we also will be having other masterclasses by our JAAFCA members and our international leaders like Anna. And finally, I would like to also invite you jointly with Professor Romel Lobo, who is the president of PASI. The Apache and PASI will join together to have this Congress, the Apache 2022 PASI at 50 in Manila from the 5th to the 8th of December. Be sure this is going to be an outstanding scientific program. It'll be a scientific treat, and we hope to see you there in person. With that, I wish everybody a very good night, a good evening, and hope to see you soon. Can we stay on for a picture?
Are we still live? All right. Thank you. Thank you all. I can't hear you, Prof. Ruby. You're muted.
Saying that let's have a picture.
Yeah, sure.
So, Shiranga, can you do it at your end?
Professor, I already took the picture.
Oh, God, she's a wonder girl, you know. Acts before I even tell her something. You know, she's already done it. Anyway, I have to say personally, thank you so much. First of all, Anna, so very much. I owe you a lot.
No, it was a pleasure. Thank you. I really enjoyed Tim and
I think
Agnes.
it was an outstanding session. Really excellent
Yeah.
thoughts. You know, each one of you were very, and there's so much information. I think, you know, we could actually have a half-day workshop on this, you know, and probably we should do that in Manila. Let's plan something like that, Agnes, for Manila. Yeah, it's
Thank
just
you.
outstanding, and we'll bring Anna there.
All right.
Okay, Anna, now have
My
a nice
pleasure.
day, and
Yes.
we'll be in
And
touch
have
with you.
Okay.
And
Good
Lydia,
night.
thank you for moderating
Thank
so
you.
well.
Recording stopped.
Thanks for the invitation. It was a treat.
No,
Yeah.
it's great. We're going to meet each other again for this steering committee in a short while, a couple of minutes, I think so.
All right.
So,
Wow.
yeah.
Bye. Thank you for having me.
everyone.
Bye. Have a
Thank
good
you.
day.
Bye-bye.
Thank you.
Hope to
Bye-bye.
see you again.
Thank you.
Bye.
See you at the steering committee. See you.
And